Welcome to the next episode of the Complete Physio podcast. I'm here with Mr. Simon Moyes, who is a friend of the show. And today I've asked him to specifically talk about ACL grafts. So the ACL is a ligament in the knee, and many people will have it reconstructed due to injury or rupture of the ligament. And there's different options for grafts, and I really want to get the detail on this from Simon because there's lots of different opinions on it. So Simon, thanks for joining us.
Pleasure, as always.
So talk to me a little bit about your journey with choosing the correct ACL graft.
So there are three main grafts now for ACL reconstructions. Historically, probably the first one that came out was the Patella tendon, where we took the middle third of the Patella tendon with a slither of bone at either end, and that probably still remains the gold standard as the strongest of all the grafts to use. And then historically along came the hamstring tendons, where people would take gracilis and semitendinosis or parts thereof to reconstruct the knee. And then more recently, people have been taking distal quads tendon. That's
over the last, 5 years?
Yes, 5 years or less, I would say.
Yeah.
Those are the three main autografts.
Yeah.
Then there's something called an allograft, which is being used, which is becoming less popular again now. And that's where you have basically a graft from a dead person.
Yeah.
And that's a donor graft. So if you've got someone who's got much lower demands on their knee, who wants a shorter, quicker operation with potentially a quicker recovery time, and the older patients, then you want to use a donor graft or an allograft for them.
Okay. And you talked at the beginning, one of the key things with the different grafts is whether you take a bit of bone off with it. Do you want to just explain what you mean by that?
Yes. The advantage of the patella tendon is it does have a slither of bone, or you can take a chunk of bone at either end of it. Now, the advantage of that is when you drill the tunnels in the shin bone and the thigh bone, the tibia and the femur, and you use that graft, you're more likely to get bony incorporation of the graft. So that's an advantage.
Because bones will generally heal very well on each other.
The outcomes, though, really, between a well-performed hamstring autograft ACL reconstruction and a patella bone reconstruction, they're very, very similar. And you'll go, or we attend meetings, and different surgeons will argue the case for one versus the other. And I think ultimately, if you're seeing your surgeon, you would have a discussion with your surgeon as to which particular graft you want to have done for your...
I'm on to that, Simon. I just want to... On the quads tendon, the relatively new one, do they take a bit of the patella with that, or is
You can do.
Right.
You can take the upper end of the patella if you want to.
Right.
We've got some surgeons in our group who are starting to use quads tendon. It's not something I particularly use myself, but it is certainly growing in popularity, and the early results are very good for it.
Yeah.
The other thing that's important to mention now, which is growing in popularity, is the extra operation, which is called the Lateral extra-articular tenodesis, or LET.
And this is something that's... Do you want to give us the background of how this came about? Because it is relatively new.
So if you go back years and years and years, back as far as the 80s, people were doing an old operation called a Macintosh procedure, which is where they would take something called the fascia lata, loop underneath the lateral collateral ligament, and that was how people controlled rotation of the knee, and that was really the predecessor to this extra-articular tenodesis.
And this is, just to be clear, this is as done as part of the ACL reconstruction.
Yes, historically it wasn't. Historically, the LET or the Macintosh was done before people were doing ACL reconstruction.
Really? I didn't realize that.
Anyway, cutting to the point, really, the evidence is now firmly out there that you have a much lower re-rupture rate of your ACL reconstruction, be it a bone patella bone, be it a hamstring, be it a quads. If you're a high-demand patient, and this roughly means probably about 50% or more of patients need this extra-articular tenodesis, which will control rotation.
even more than just
even more than a standard ACL reconstruction.
So you're doing this in a majority of your cases?
I think so now. Yes, you find that more and more people are being offered it.
Yeah, absolutely.
And it's your younger patients.
Yeah,
it's those patients that might be hypermobile. There'll be those patients that are heavier, that want to get back to sports that run the risk of re-injury to their knee. So when you actually analyze it, it's more and more patients are being offered it and indeed want it.
Does it? 2 questions. I assume you have to do a cut.
It's an extra scar.
And does it slow down recovery?
And I think it does slow down recovery.
I'd agree.
Yeah.
I mean, I don't think it's significant, but well, no, I think it is significant, but at the end of the day, people, certainly unless you're in elite sport and you're getting paid 150 grand a week, the odd week probably doesn't make too much of a difference.
Yeah.
But we do find it can sometimes be a little bit sore around that area afterwards.
And a bit more stiff, I think.
Yeah, absolutely. So let's talk about each of those different graft options. And let's talk about you've talked a little bit already, but let's talk about the pros and potentially the cons, which we haven't talked about. So starting with the traditional patella bone.
The patella bone is, you have a long scar over the front of your knee.
Yeah.
So a lot of people don't like that. It's quite a visible scar. And probably about 5 or 10% of people will get what's called anterior knee pain. And they will get that typically when they kneel, which can be annoying.
Yeah.
And if you're in that unlucky group, you're probably stuck with it.
Yeah.
Then when you take the hamstrings,
just going the other case I had, this is going back a few years because I don't think most surgeons would do it, but back in the day that was the common operation, wasn't it? And I remember a basketball player, and a volleyball player who had terrible anterior knee pain afterwards, because obviously their sports are the type of sports where you're going to be prone to patella tendon problems. And so those were 2 cases I remember where there's no way people would do a patella bone now, or I don't think they would, because of that risk of the anterior knee pain.
So I think they are probably still being offered it because it still does remain in most people's minds the gold standard for the strongest graft. I don't operate really on elite sportsmen or women, but my colleagues that do, they'll describe that these patients have much bigger patella tendons, and they can take much bigger grafts.
These weren't big guys.
So I think that's probably...
and actually one had a history of patella tendon problems.
Okay, there you go.
Which would make you think that the graft is not as strong as... So maybe there's a few things that could have been learned from that case. Okay, so generally patella bone is really strong, gold standard in terms of strength, because you've got this plug, this bone.
And also you can dial it up. You can dial up exactly how broad a graft you're going to take.
Let's talk about that now. So people would have heard of double bundles, triple bundles, quadruple bundles.
So the bundles all relate to the hamstring tendons.
Yeah.
But for the patella tendon, you just use a block and you take 9, 10, 11 millimeters in diameter with a relevant sized bone block at either end.
Yeah. So you could take a thicker graft, couldn't you, for the patella tendon?
Yeah.
But bearing in mind, when you look at these patella tendons on ultrasound that have had an ACL, it's unbelievable how much of the tendon is missing and they're functioning okay.
Yeah, it is.
Yeah. Quite scary. Hamstrings?
Hamstrings, again, they can be taken through different incisions, a small vertical incision, a more oblique incision. And there are some surgeons that do an arthroscopic all-inside technique, whereby they just need to take just one of the hamstring tendons. That's very helpful. That's done now. But one of the potential downsides, or historically one of the downsides of taking hamstrings, is you're sort of robbing Peter to pay Paul, as it were. So the hamstrings are important stabilizers of the knee, and you can have hamstring weakness post-harvesting of the hamstring graft. So that's always been an argument of one of the problems of using the hamstrings as an autograft, as my understanding. And you could also injure a small nerve in taking the hamstrings, which can leave you with pain down the inside of the leg. That's rare, but it's, you have to consent people for that.
Yeah.
And then because of the problems that people have been having with patella tendon donor sites and because of hamstring donor sites, there's been a trend, an increasing trend, as you say, over the last 5 years, to people to start I won't say playing around, but using the distal quads as a donor. And those colleagues of mine that are using it, they're fans.
I mean, the quads tendon, when you look at it, it's a big tendon, isn't it?
Yeah.
And quadriceps tendinopathy or problems with the quads is way less common than patella.
Yeah.
So it does make sense from that point of view, doesn't
Yeah,
it?
so I think the early results are favourable and more people are embracing it.
I wonder why they went for the patella tendon in the first place.
That's a great question.
Something would have just done it once and it worked and they kept going.
Yeah.
Going back to the hamstring, if you look at Premiership, I was reading something about, hamstring injuries in the Premiership this year, and they're going through the roof. Despite all the technology we have and everything, the number of hamstring injuries and big hamstring injuries is growing.
Yeah.
So is there a tendency, I know you don't work with loads of elite footballers, but do you think the tendency as well is because of as you say, you're taking away the hamstring, there's a massive issue with hamstring injuries in football? Do you think that also
what I see is something different. So I see proximal hamstring tendon tears right up and the ischial tuberosity on your sit bone, where they get badly injured, and then we see them, and then they get sent off to a hip surgeon to have them reattached and repaired.
Yeah.
That's what we see.
But I suppose if you've done a hamstring graft, that potentially is it's definitely going to change the way the muscle works.
Yeah.
So if you're prone to hamstring injuries, you're in a sport where you have lots of hamstring injuries, it might be worth thinking about another type of graft. Yeah. So again, what we're getting here is that it's very specific to that individual.
Yes, but just chatting to my colleagues that I do who do operate on elite sportsmen and women, it is not as big a problem as you or I would think.
Right, yeah. Sure. Yeah. So as in a majority do well.
Yeah.
So why did we look for another option if hamstring? That's life, isn't it? Yeah, people always. Yeah. So tell us a bit more about the quads tendon. Oh, going back to the hamstring, talk to us about the bundles, because that is something people will want to know about. The double bundle.
So what you need when you're doing an ACL reconstruction is you need a graft of a certain thickness and a certain length. And without blinding everyone with science, you need to manufacture from your donor side, from your hamstring tendons, a graft of that length of thickness. So it'll be down to double bundle, triple bundle, depending upon what the quality of the graft is.
Right.
When you get there on the operating table.
So you're when we say bundles, you're putting them next to each other to get a certain thickness.
They're literally like little bits of little worms of rope, and you're trying to manufacture a sufficiently long and thick graft to reconstruct your ACL.
So in some patients, you'll need to use semitendinosus and gracilis because of that fact, because they don't have big hamstrings. And
those surgeons that are using the arthroscopic all-inside technique, they can often get away with one tendon.
Which one would they generally use?
They use semitendinosus.
Yeah, which is the most common one used, isn't it? And then let's talk a little bit more about the allograft. So the autografts are where you take it from the patient themselves, the donor. And what about the allografts?
So allografts, there was early data which suggested that allografts had as good results as autografts, but allografts have really fallen out of popularity now because there's a much higher re-rupture rate. So you tend to reserve allografts, I think, for your much older patients, much lower demand patients.
Right. But is that with or without a lateral tenodesis?
So I think with the older patients who really low demand, they're probably not going to need an extra-articular tenodesis as well.
Yeah.
But again, you need to have a conversation with your patients so they fully understand the pros and cons of autograft versus allografts and whether or not they need this lateral extra-articular tenodesis.
And from a surgeon's perspective, let's say I wanted to have my ACL reconstructed and I came to see a surgeon and they said, well, I've done sort of 80-90% of my experience of ACLs as a hamstring graft.
Yeah.
But actually there's this new data that says quads is pretty good. What would you go for? Would you go for this relatively new data, or would you trust the surgeon and go with the process that they've used for many?
I think you've got to trust your surgeon.
Yeah.
Certainly get one or two opinions.
Yeah.
By all means. But trust your surgeon is to do whichever technique he or she is best at doing.
Most confident.
Yeah. So there'll be some surgeons who've historically done more BTBs than anything else. There'll be other surgeons that will be brought up on hamstrings.
Yeah.
But most surgeons these days will be able to do most of the graft, most of the options,
Sure.
even though they'll probably have one that they favour.
Yeah, because this is such an established operation now, isn't it?
Very
I mean,
common.
it's 20, 30 years.
Yeah.
I know you're a skier, Simon.
Yes.
So dare I say next year when you go skiing, if you injured your ACL, which I'm sure won't happen, what graft would you have and why?
Oh, my God. So I'm in my 60s, and really all I do now is go to the gym, go for the old run, bike ride, and ski. So strangely, I'm going to say I'll probably go for either a hamstring autograft or I would go for a allograft, one of those two. And I think I'm still a bit undecided.
Okay.
But hopefully I'll never need to make that decision.
I'm sure you won't, Simon. That's very interesting. Thank you very much for the time.
Pleasure.